So chemotherapy. Uh, we start with the chemicals substance for the treatment of any disease. So chemotherapy is nothing but the treatment of disease with the help of some chemicals. Question is which chemicals, which are the chemicals are used for the therapy? So there are many chemicals which are present in our surroundings, but each and every chemical cannot be used for the diagnosis or prevention or the treatment of any disease. So there should be one basic criteria should be present so that we can call a chemical as a drug and we can use that drug for the treatment. That is known as chemotherapy. So in case of chemotherapy, for any kind of chemical used for treatment, this is based on a criteria known as ratio of benefit divided by risk. So this benefit divided by risk, this ratio determine that the chemical substance would be called as a drug or we can use that chemical for a treatment. So the ratio equal to beneficial effect divided by the risk or harmful effect. So this is the ratio of beneficial effect or harmful effect. When the ratio is high, means beneficial effects are more than the harmful effect. When beneficial effects are more than the harmful effect, we call that chemical as a drug and use for the treatment. And this comes under your chemotherapy, where we use the chemical for the treatment based on the ratio of beneficial effect by harmful effect. This chemotherapy, general chemotherapy has some definitions or terminology. Like the first terminology is known as antimicrobial agents. These antimicrobial agents, they may be natural or semi-synthetic, semi-synthetic, or they may be synthetic. So the natural antimicrobial substances are known as antibiotics. Antibiotics means against the life. Then semi-synthetics, they are obtained by modification of the natural ones. And these are the synthetics, example fluoroquinolones and sulfa drug. So in case of chemotherapy, these are the two class of drug which are synthetic in nature. So these fluoroquinolones and sulfonamides, they are not called antibiotic. They are not antibiotic. So we call them as synthetic antimicrobial agent. And the natural ones, they are called antibiotics. And these antibiotics are produced by FB, that is fungus, bacteria, and A for actinomycetes. So these are the three sources. These are the three sources which produces antibiotics. Then the definition of chemotherapy itself include two important. term. That is, in case of chemotherapy, it is based on selective toxicity, plus also included anti-cancer drugs. Selective toxicity means there is a microorganism and the microorganism have one mechanism for the survival. If we inhibit this mechanism, the survival of the microbe will be lost. So selective toxicity means that mechanism which is selectively inhibited by the agent and that mechanism lead to loss of survival. So the mechanism which is present in the microorganism and this mechanism is not present in the host. So there are two things, one is host and one is microorganism. So mechanism used by the microbes but not by the host. For example, in case of bacteria, in case of bacteria, they synthesize all their DNA amino acid. DNA molecule is important for this bacterial cell to divide into two. And the source of this DNA, they are the nucleotide. And nucleotide precursors, they are formed by some molecules like folic acid or para-amino benzoic acid. So these bacteria, they have one mechanism to synthesize folic acid. And the pathway is from para-amino benzoic acid to folic acid. So this is the mechanism for the survival of bacteria, where they start with the PABA, para-aminobenzoic acid, then synthesize folic acid, nucleotide, DNA, or RNA or protein. So these are the biomolecules, these are the life molecules which are important for the division of the bacteria 1 to 2 and also for the functioning of the cell. So these mechanisms which are important for survival, these mechanisms are disrupted by drugs like sulfonamides. But in case of host, they do not utilize para-aminobenzoic acid to synthesize folic acid. So in case of host, they utilize preformed folic acid. Preformed folic acid. So one mechanism which is present in bacteria important for its survival but not present in the host. So in this case, the selective toxicity selectively toxic for the survival of microorganisms. So these microorganisms are selectively killed. They may be your bacteria, fungi, protozoa, and other things. The second important things which is related with the definition is anti-neoplastic drugs. They are also included in the definition of chemotherapy. There are two reasons for that. These are the normal cells of the body which start behaving abnormally. So these are the normal cells and they start behaving abnormally. Second case, the anti-cancer, these cancerous cells, example in case of dog, there is canine TVT, transmissible venereal tumor. And this tumor is the only tumor in veterinary that is infectious in nature. Infectious in nature means this tumor is capable of infecting male to female or female to male. So from one animal, these canine TVT cells, they are infective in nature. So, chemotherapy based on selective toxicity, and the second thing important is the definition also include anti-neoplastic drug. The reason for this, normal cell behave abnormally as a foreign cell, or they may be infective like canine TBT. And selective toxicity means selectively killing the microorganism cell. So antimicrobial agents like antibiotics, or they may be semi-synthetic or synthetic. These are the three categories. Antibiotics are natural and synthetics are two fluoroquinolones and your sulfur. Then antimicrobial activity. There is two types of activity. Antimicrobial activity. Ag- The activity against the bacteria may be bacteriostatic or bactericidal. Static means, suppose this is the cell of the bacteria having ribosome. The drug, this drug will come and bind and stop the protein synthesis. So these are bacteriostatic. That may lead to inhibition of the growth. Means bacteria are present inside the body, but their growth is inhibited. In case of cidal, in case of bactericidal, they directly kill. They kill the bacteria. So the clinical importance of these drugs like bactericidal or bacteriostatic. What is the clinical importance? Suppose these are two patients. One is having functional or healthy immune system, and this is having compromised immune system. If you give bacteriostatic drug to the healthy immune system patient, healthy immune system, then that bacteriostatic drug will lead to the inhibition of the growth, and that inhibited bacteria, they are cleared by the immune system. So, but in case of compromised immune system, if we give bacteriostatic drug, the drug comes, this is bacteria, it will inhibit the growth of bacteria stopped, but the immune system is weak. So after some time, the bacteria again start multiplying. So this is the case where we cannot go for bacteriostatic drug because they stop the growth of bacteria and the immune system is weak. So the immune system is unable to clear off these bacteria. So these bacteria again start multiplying and they may flourish again. So in case of weak immune system, the preferred choice will be your bactericidal drug because they kill the bacteria. So if the immune system is weak, it can easily clear off. Then these bactericidal drug may be of three types. So based on activity, static and cidal. We have two types, static and cidal. And these cidal are of three types. One is time dependent killing, one is concentration dependent killing, and another is both. So these two are more important, known as time dependent killing and concentration dependent killing. In case of this, Suppose this is the MIC. If we give a single dose, that is your concentration. So this concentration is enough to remove or destroy all the microorganisms. But in case of time dependent killing, we need to give the drug multiple times a day so that the concentration remain high above the MIC level. But in case of concentration dependent killing, we need to give once a day dosing. And here we need to give multiple dose. Multiple dose. Example is aminoglycoside, for example, gentamicin. Gentamicin. So the dosing of aminoglycoside gentamicin is once a day. That is, it follow concentration dependent killing. It will kill when it is present in high concentration. But the opposite multiple dosing concept, this is related with your penicillin. In case of penicillin, multiple dosing is recommended where MIC, the concentration remain above the MIC, minimum inhibitory concentration. So these are two types of killing or two types of bactericidal effect where one is dependent on the concentration and other dependent on the time. This is dependent on the time because we have to administer drug multiple times so that our concentration should not fall below the baseline, that is your MIC. So these are two types of bactericidal action. One is dependent with the time, we need to give multiple doses. One is related with the concentration. We give once a day but high dose. So this is sidal and static concept. There are some combinations like bacterium. If we combine two bacteriostatic drugs, the result will be additive. Their action will be additive. If we combine static plus sidal, they will antagonize. Antagonize. They will antagonize each other. So these are the combinations of bacteriostatic and sidal. Next is the activity, antimicrobial activity, that can be measured by the term MIC, MBC or MAC. Based on MIC, ICAR 2020, they have asked one question, that which of the following method is used to measure or used to determine MIC values. So the options were broth dilution, broth dilution method, and second was epsilometer. So first method, MIC, how to determine the MIC. First is broth dilution. Broth means liquid. Suppose there are following concentrations and these are the figures or concentration. This is 2
Excuse me, sir, you are not
microgram,
audible.
4, 8, 10, 16, then 32 and 62. Drug is added in all the cases and bacteria is present. MIC is the minimum concentration at which growth is inhibited. So we cannot see the growth. Suppose this is the concentration, that is 8. If 8 is the MIC, then the growth is inhibited for the first time in this case. So in all these other beakers, we take this and try to see after 24 hours that in which one bacteria are killed. Suppose this is the 32 one, MBC. So MBC is the minimum concentration where you will find the death of the bacteria, killing of the bacteria. So MIC is the minimum where growth is inhibited, and MBC is the minimum where death of the bacteria. So these are parameters which are obtained from the growth dilution. So these are the liquid or broth which are diluted and drug is added, bacterial sample is also added. If you find the lowest concentration were inhibition of the growth, we call it MIC. If there is death of bacteria, MBC, minimum bacterial sample. One more term is MAC, that is minimum antibiotic concentration. Minimum antibiotic concentration. So this term is also related with the inhibition of growth. Just like MAC means inhibition of growth, but while it is log 1. That is log 1 means 10, log 1 equal to factor 10. So if the growth is inhibited by a factor of 10, we call it MAC. And if this the minimum concentration where first time growth is inhibited, MIC. If bacteria are killed, minimum bactericidal. The first time they are killed, that is MBC. So these are the growth dilution method. And second is E-test. In case of E-test, suppose this is your media, and we take one strip which is impregnated with antibiotics like 1 microgram, 2, 3, 4. In this case, the antibiotic start killing the bacteria in its round. So this type of zone will be found. So we start with A. Hello, hello.
Sir, you are audible.
Okay. क्या मैसेज दिखा रहा है? So, one method is growth dilution and second is the E-test. In case of E-test, we take one strip and this strip contains different concentration of the antibiotic, your drug. So if we put this into a media where bacteria are present, then the antibiotics start killing the bacteria and it will clear the bacteria and make a zone. To measure the MIC, we start with the lowest concentration, where the first time bacteria are killed or inhibited, growth is inhibited. So suppose this is the MIC equal to 1 microgram. So this is a simple E-test where we take a strip and impregnate it with the antibiotic and it will start showing its effect and clear the surroundings area above the bacteria, then we measure from which point it was started. That will be our MIC. So these were two methods, growth dilution and e-test for to determine the. Then there is one more concept that is post-antibiotic effect. Post-antibiotic. The name itself, when antibiotic is not present or it is present but in less concentration. Suppose this is the point the dose was
Sir,
given
your voice is not
and
clear, sir.
this is your plasma concentration.
Hello, sir,
That
your
is
voice is not
given
clear.
the plasma concentration. After some time, it will start decreasing and it will reach at this baseline before MIC. In some antibiotic like your aminophylline, it will move like this. So this point, this curve is known as PK. Means the concentration of your antibiotic is below the MIC. Normally, when the concentration is below MIC, there is no effect. But in case of aminoglycoside, we give once a day dosing, high concentration, it keep on reducing, then it goes below the MIC and also showing effect for few hours. And this effect is post-antibiotic effect, and this effect is because of the at this point the bacteria, some of the bacteria they have become weak and they are also cleared by the immune. So even the drug is not present or it is present below the MIC, still we can find some amount of effect. That is post-antibiotic effect. Effect after, yeah, means post or after the antibiotic is cleared off from the body or it is just below the MIC. So this part is known as post-antibiotic effect. And the most common example is amino glycoside. Then there is one more effect we call biphasic effect. Biphasic effect means there are two phases. There are two phases. Two phases means at low concentration, at low doses, there are some antibiotics at low doses or second is at high dose. At low doses they call lysis, but at high doses not lysis. Such wide-ranging effect is shown by Paris and Chase. We call it biphasic effect or as the name
Doctor, your voice
indicates,
is not clear.
where there is at low doses there is lysis of bacteria, but at high doses there is no lysis. So
Your voice is
even
not clear, sir.
effect are same, so we call biphasic effect. Two effect at two doses. At low dose, lysis of the cell, high doses, no lysis. And this effect is most commonly shown by the
Sir, your voice
Your
is not
voice
clear,
is
sir.
not clear.
then coming to one common topic that is drug resistance. Drug resistance. It is of two types. One is natural
Sir, your
and
voice is not
second
clear, sir.
is acquired. Hello.
Yes, sir. Voice is not. Your voice is not clear, sir.
Okay. Hello. Hello.
Yes, sir. Now you are audible, sir.
Am I audible?
Yes, sir.
I think it's Bluetooth. One second.
Hello. Okay. Oh, it's audible. So the drug resistance is of two types. One is
Please start
natural.
from biophysics effect.
Okay, five physical. Biphasic effect. See, this is the low dose of your penicillins, and this is the high dose. At at low doses, they say there is lysis of the cell, bacterial cell, but at high doses there is no lysis of the cell. Means this lysis is bactericidal effect, and no lysis you can say this is bacteriostatic effect. That is at two different concentration or at two different doses, two phase effect is shown, that is biphasic effect, and this is shown by the your penicillin group of drug. Then drug resistance is mainly of two type. Drug resistance. One is natural and one is acquired. This natural one is the inherent property of a bacteria. Suppose there is one Pseudomonas bacteria. It is one of the gram-negative bacteria, and this is the cell wall of the bacteria. In the wall, there are present normally gram-negative have some pores called porins. Through these porins, drug may enter. But in case of Pseudomonas, these porins they may be very, very narrow, or they may be absent. So this is the inherent mechanism to protect the bacteria from the drug. Either there may be a reduced number of porins, or if porins present, they may be of small size or small lumen, so that our drug unable to enter the bacteria. So this is example of the natural inherit, inherited resistance. And the second one is the acquired resistance. Acquired means Acquired means initially this was the bacteria and it was sensitive. It was sensitive. Some kind of mutation or gene transfer occur in the bacteria that may lead to one more bacteria, that is resistant bacteria. Resistant one. So in case of acquired resistance, this bacteria was previously sensitive, but because of some mutation or some method of gene transfer, it now becomes resistant. So this acquired resistance is of two types, that may be because of mutation. The rate of mutation is 1 is to 10 to the power 8 cell. But the important thing of mutation, it is vertical. This is the parent cell, this is the parent cell, and these are the daughter cell of the bacteria. These two are the daughter. So from the parent to the daughter, this mutation transfer the resistance. So the resistance which is vertical in nature, parent to daughter cell, is because of mutation. And that mutation may occur in single step. Single step. Single step means there is bacteria, this is the gene of bacteria, and suppose this gene is responsible for producing some proteins, and our drug act on that protein. If because of some mutation, this gene it start producing some different shape of enzyme, then our drug is unable to recognize the target. So single step mutation means there is a large mutation in a piece of DNA that may lead to resistance. And opposite to this, multi-step mutation means the same thing happens in 2 or 3 steps. So the mutation is vertical type of transfer, parent to daughter cell resistant transfer that may be in single step, that is a single gene which gets mutated and that may lead to resistance. The example is your MRSA bacteria, methicillin resistant Staph aureus. This bacteria have one gene and the name of gene is MAC-A. Normally they have penicillin binding protein, and this penicillin binding protein get mutated and it becomes penicillin binding protein 2A, and this our drug is unable to recognize this protein binding penicillin binding protein 2A. So in case of MRSA, there is MAC-A gene which code for penicillin binding protein, and this protein get mutated. So this is the example of mutation, single step large mutation, MRSA. Next is the acquired resistance. First mechanism was by the mutation and second is by the gene transfer. This method is vertical and this is horizontal. Means from one bacteria, this is another bacteria, conjugation tube, the resistance gene directly transfer to the other bacteria. So we call it horizontal method of gene transfer. So the first method is most important method is conjugation. There is one conjugation tube formed in between the bacteria and transfer of the material. Second is transduction. This is the method where this is the bacteria. In this case, the bacteriophage carry the gene and it transfer to that resistant gene. So this is transduction via phage. Third is transformation. Transformation. This is the bacteria. Suppose in the surrounding one bacteria died. Because of the death of that bacteria, what comes out? The DNA material. And this DNA material, if carries some resistant gene, then this will be taken up by the bacteria, this A bacteria, and it will also become resistant to some drug. So mutation, vertical method. Gene transfer, horizontal method. Horizontally, one to other, by the tube, by the virus, or directly from the surrounding. So Transformation is a simple method where naked DNA naked DNA is uptaken from the surrounding. So this is the DNA bacteria. Suppose this bacteria died and this DNA also fragmented. There is one more bacteria and it takes this naked DNA, naked DNA from the surrounding area. So we call this method is transformation. Transformation. So these are three methods. Then some biochemical mechanism of resistance. Next topic is biochemical mechanisms. Suppose this is the bacterial cell. This is the bacterial cell. And this is the target of our drug. This is the target. So the first mechanism is just to alter the target. The target is square shaped, it may become star shaped. So the drug is unable to recognize the new form target. So first mechanism alter the target. Second mechanism efflux means the drug enter and it is efflux outside of the cell because of some efflux pump. So they throw the drug outside. Third mechanism suppose there is one pathway A to B to C. They alter the pathway. Means from A they start using and forming the compound D directly A to C then D. They do not stop utilizing the B. The best example of alternate pathway is sulfonamide resistant to sulfonamide. They use para-aminobenzoic acid, THF, then this your folic acid. So what they start doing? Stop the using PABA. They start using preformed folic acid. In this way, they alter their pathway. So there are three mechanisms. First is alter the target, throw the drug out through efflux pump, or alter the pathway. One more mechanism is these bacteria they start secreting some enzymes, and these enzymes they destroy our drug, and these enzymes are known as beta lactamase. Beta lactamase production of enzymes. So these are some common uh, biochemical mechanisms where the bacteria try to protect itself from the action of drug. It starts changing PBP, that is example of penicillin. Through the outside, this example is for tetracycline. This is for your penicillin. This is for penicillin. Efflux is for tetracycline, and this pathway for sulfonamide, and this enzyme secretion also for the beta lactam as well as amino glycoside. This start secreting enzyme. So these are some biochemical mechanisms where the bacteria try to protect itself from the action of drug. Then the next topic is sulfonamide. There are two class of drug. We call them synthetic antimicrobials. They are not antibiotics. They are simply known as synthetic antimicrobial agents. They are not antibiotics. The first we start with sulfa drug or also known as sulfonamide. Sulfonamides, the history is related with the Pronto cell dye, and this pronto cell dye was able to kill the streptomyces bacteria. So this pronto cell dye contains one active molecule. We call that molecule as sulfanilamide. Sulfanilamide. So this is the active molecule. All the sulfonamide which are present today in the market, they all are nothing but derivative of this active molecule sulfanilamide, which was present in the prontosil dye. And this dye was able to kill the bacteria, stop their growth like streptomyces in mice. So sulfonamide, their mechanism of action, if you look at, there is para-amino benzoic acid. This para-amino benzoic acid, this is utilized by the bacteria. Then again, there is formation of dihydroteroic acid, dihydrofolic acid, and tetrahydrofolic acid. And then it may lead to formation of your biomolecules, DNA, life molecules, RNA, and amino acid. So these enzymes are blocked by sulfonamide drug, and this is blocked by trimethoprim. So this is a simple example of competitive enzyme inhibition. Means these sulfonamides, they compete with the para-aminobenzoic acid and they win the competition. They block this enzyme and they block the first step of formation. Similarly, the another molecule trimethoprim, they also block enzyme and that may inhibit the synthesis of DNA, RNA, which are essential for the division of the cell, and if they are not present, the bacteria will die. So this is the metabolic pathway where these bacteria utilizes some molecule and they synthesize folic acid. Uh, Related with their structure, two important concepts are nitrogen 1 and nitrogen 4. The metabolism of sulfonamide is by acetylation. Acetylation. So in case of N1 acetylation, these compound becomes water soluble. If we do the acetylation, they becomes water soluble, and if we do the acetylation at N4, at this point acetylation will lead to decrease in water solubility. At this point, increase water solubility. So if we decrease the water solubility, chances of crystal urea will be more. So more crystal urea. So nitrogen 1 and 4, they are related with the acetylation mechanism. One increases the solubility, less toxicity, and less chance of crystal urea. But N4, acetylation, less water soluble, chance of crystal urea will be. Then some species difference like cattle and dog. Pharmacokinetic related with cattle and dog. In case of cattle, there is extensive acetylation. In case of dog, acetylation is absent. Acetylation is absent. So no acetylation means chances of crystalluria will be less. Extensive acetylation means metabolite will be formed, and in case of acetylation, the metabolite is always less water soluble. If it is less water soluble, that may lead to increased chances of crystal urea. So in case of cattle, sulfonamide are more toxic than dog. So in case of dog, acetylation absent, so no crystal urea, no renal toxicity. So if acetylation is absent, then the mechanism instead of this one, what is present is formation of your glucuronide conjugation. And this glucuronide conjugation, as we know, it is a water soluble molecule. Make the metabolite water soluble, it will easily excrete out from the body. So this concept happens in the dog. Then toxicity. Sulfonamide, they have renal toxicity. Renal toxicity. How to reduce this renal toxicity? So chances of crystal formation is more. So we can increase the water intake. If the animal take more water, then the chances of crystal urea will be less. Precipitation of crystal will be less. Second method we can apply is law of independent solubility, where we combine 2 and 3. Two or more sulfonamide, because of their combination, overall solubility of the product will increase. So there will be less chance of crystal deposition. The third thing, if the urine is acidic and the chance of crystal deposition is more, so we can make this urine alkaline by using NaHCO3. So these are the three mechanisms where we use these and try to decrease the risk of crystalluria by increasing water supply and by using this combination of sulfur called, if we are using three, called triple sulfur, and we can also give bicarbonate to make the urine of dog and cat alkaline. So this acute toxicity for renal is very important. The second question in 2019, they have asked about the poultry. So, in case of poultry, if we use chronically one drug, it is quinoxalin, sulfaquinoxalin, sulfaquinoxalin. If we use it chronically, it may lead to deficiency of vitamin K, and all the vitamin K dependent clotting factor, they will be absent, and that may lead to bleeding in case of poultry. Poultry. So this was MCQ, that which of the following sulfonamide lead to the vitamin K deficiency? Answer was sulfaquinoxalin. And one more chronic toxicity with poultry is, in case of uterus of the bird, there is one enzyme, carbonic anhydrase. Role of this carbonic anhydrase is the formation of egg shell. If the sulfonamide or sulfa drug, they inhibit this enzyme, then the shell will be thin or maybe absent. So this thin or shellless egg may be produced in case of poultry. So these were two chronic toxicity related with the poultry. And one more is related with the dogs. It was also asked in 2019 that in case of dog, these sulfonamide they may cause condition KCS, that is dry eye. The dry eye may be due to direct lacrimotoxic effect of the drug, directly destroy the drug, or that may be because of immune system mediated complex formation. So dry eye is important in dog related with the sulfonamide toxicity. Then there are some antagonists of sulfonamide. There are some molecules, if they are present, there are some antagonists like pus. So pus is a collection which is rich in para-amino benzoic acid, and this para-amino benzoic acid reduce the efficacy of our drug. Other molecules are also present like protein, gelatin, some other proteins, vitamin B. All these are the antagonists. They reduce the activity of sulfonamide. So in case of sulfonamide, these points are important like the discovery of sulfonamide related with the prontosil dye, then active molecule, your sulfanilamide, then there are presence of two nitrogens, one N1 and another is N4. Distillation of this make it more water soluble, less toxicity. And this. So crystalluria is seen with sulfonamide as well as your fluoroquinolones. The resistance mechanism. In case of sulfonamide, they follow the pathway like from para-amino benzoic acid, they start folic acid, then they form their DNA. So the alteration is metabolic pathways like this. They stop using this molecule. From the diet, they start using preformed and they form their DNA and keep surviving. So this is the main mechanism, drug resistance mechanism with the sulfonamide. Then there is one more class known as potentiated sulfonamide. Potentiated sulfonamide are combination of sulfonamide plus molecule like trimethoprim. One MCQ asked with this combination was this sulfona S look like 5. The combination was 5 is to 1. These drugs are combined in ratio of 5 is to 1. Sulfonamide with trimethoprim, and the combination is known as potentiated sulfonamide. Because of combination, they becomes bactericidal. Normally, sulfonamide are bacteriostatic drugs, but they become bactericidal. Then there are many the classification of this sulfonamide like long acting, short acting, topically or systemic acting. So with this classification, the important concept or important example they are number one is your mefenide. Why mefenide? Because in this case, normally sulfonamide have like nitrogen and here nitrogen. But there is one methyl group between the N4 and your ring. In between two, there is one methyl group. So this is not a true sulfonamide. Because of that, it is also not inactivated by presence of pus. So it is not a true one because of presence of this methyl group. The second synthetic class where we use the term synthetic antimicrobial agent. No, we do not use the term antibiotic. Is your quinolones, also known as. There are two terms, quinolones and fluoroquinolones. If they ask you number of generation as per the term quinolones, then there will be second, third, and fourth. This generation contain only quinolones, but these three, two, three, four, their member are fluoroquinolones. Means this is the molecule where fluorine is added, F. So there are only three generations of fluoroquinolones. But if they ask about quinolones, there are total four generations. The first MCQ is. Second is their mechanism of action. Normally, this is the DNA. When the DNA start replicating, so from the replication fork, if you move this side, the DNA become tight. It becomes tight. We call this supercoiling. Supercoiling. Suppose there is one enzyme, helicase enzyme, it is moving in this direction, then the area which is in front of this become very tight. So if we do not remove these supercoils, replication will automatically stop. There will not be replication. So for that, normally bacteria or human being, they have one enzyme that is known as your DNA gyrase, also known as topoisomerase 2. This enzyme normally present in the cell and it remove this supercoil so that this DNA also get open and the replication goes on. So in case of fluoroquinolones, what they do, they inhibit this enzyme. Fluoroquinolones, they inhibit your DNA gyrase. Then the DNA gyrase will not be able to open the DNA or will not be able to remove these supercoils. Then replication will stop and death of the bacteria. So if there is death of the bacteria, we call them bactericidal drug. So if we look at the structure of the enzyme has two portions. This is having two portions. Subunit B and A. Subunit A is the target of your fluoroquinolone. There are two subunits. The fluoroquinolones they target A subunit of your DNA gyrase. This MCQ was asked in 2020 Veterinary Sciences. That your fluoroquinolones target which enzyme? Answer is topoisomerase 2 or DNA gyrase. Or one MCQ was these fluoroquinolones they stop which step? Transcription, replication, or translation. The answer was replication. They inhibit the DNA replication. This is related with the mechanism of fluoroquinolones. Then there are some side effect or adverse effect which are related with your fluoroquinolone. Number one is arthropathy. At the joint, cartilage is present they damage this cartilage. That is your arthropathy. Damage the cartilage. Second is crystalluria. Crystalluria. They also lead to precipitation of crystal in the urine. And the third is on chronic use. In case of cat, there will be blindness. So these are the three important your adverse effect of fluoroquinolones. Then there are total four generation, and in case of fourth generation, there is one drug called moxifloxacin. Moxifloxacin. It is commonly used in ophthalmology as your eye drop. And the first generation, there is only one member, nalidixic acid. It is used as urinary antiseptic. Urinary antiseptic. It concentrates more in the urine and it is suicidal for the bacteria. Then the prototype drug for veterinary is the enrofloxacin, where we use it for the soft tissue or respiratory tract infections. Then next we start with beta-lactam antibiotics. There are beta-lactam groups. So beta-lactam. The trick to remember, mnemonic to remember is PCM, not physics, chemistry, math. It is P stand for your penicillin, and there are two C. One is cephalosporin, and the third is carbapenem, and M for monobactam. Monobactam. So this PCM is your beta-lactam group. So beta-lactam is a four-member ring. If we fuse this ring with five carbon member, then it will become your penicillin. If we fuse this with six-member ring, six member, then it will become your cephalosporin. Mono means one, bactam means beta-lactam. So there is only one beta-lactam. So this is the simple structure of your penicillin, where P stand for 5, but in all the cases this four-member ring remain same. This ring is your beta-lactam. And if five-member, penicillin 6, cephalosporin only one, monobactam. So if we start with our first member, that is your penicillin. This is your penicillin. Five member and four member. On enzymatic digestion, if we digest hydrolyze, this is the side chain. This beta-lactam ring. Then the enzyme will be A for amidase, and the product will be A for amino penicillic acid, APA. Then if we cut the molecule with pelicinellage, then P for P lead to formation of penicilloic acid. This molecule responsible for your hypersensitivity reaction act as a antigen or hapten molecule and cause the hypersensitivity. This 6-APA molecule, this is known as basic nucleus. Basic nucleus of the penicillin. Then mechanism of penicillin. Penicillins are the beta-lactam member. They bind with one protein. Suppose this is the bacteria cell membrane having one target, and this is the cell wall. This is your cell wall, and this is our penicillin. This box, your beta-lactam box, it comes and fit into this like. So this is the target of your beta-lactam or penicillin, and this target is known as penicillin binding protein. One more name is transpeptidase enzyme. So PBP is the target for your penicillin group or transpeptidase. The mechanism behind this transpeptidase is the basic units of bacterial cell wall. They are NAM, NAG. In case of this basic unit, NAM contains some amino acid. Suppose this is the next NAM and NAG. It also contains 1, 2, 3, 4. So the role of this is your bacteria and this is your penicillin binding protein. Penicillin binding protein. This penicillin binding protein or transpeptidase, it cross-link these peptide chain. This is one peptide, another peptide. It does cross-linking. If we block this enzyme, there will not be any cross-linking. So because of this, cell wall becomes loose, and because of osmosis, suppose this is cell wall, it keep on accumulating the fluid, and that may burst out your bacteria. So this is called osmotic burst, where the bacteria dies because of osmosis. So the cell wall made up of some basic unit, and these unit have peptide, and these peptide are cross-linked by your enzyme. If you block this enzyme, no cross-linking, wall becomes loose, more fluid enter, and more fluid enter, bacteria will burst. And this is the death of bacteria. If there is death, then we use the term bactericidal. So this is the mechanism of your penicillin. Then with the pharmacokinetic ADME of the penicillin, if we look at the more important is there is no metabolism of penicillin. It means they are simply excreted out by your kidney. In the kidney, 20% by glomerular filtration that will come out, but the 80% through this cation pump, 80% tubular secretion. This is important. If they ask you that which of the following is the main mechanism of excretion of the penicillins out of the body, answer will be tubular secretion, because 80% comes out through this. There is no metabolism in the liver, the drug excreted as such. Then there is one more molecule, just like your penicillin binding protein. There is one more molecule. This molecule is known as autolysin. Autolysin increases the breakdown of cell wall. It helps in the remodeling of cell wall. Keep on degrading and keep on synthesizing. If it start degrading the cell wall, if we give our penicillin and they activate this autolysin, it will start digesting the cell wall. So one mechanism is penicillin binding protein, make the wall loose, bust the bacteria. Second is the mechanism autolysis activate them. They start degrading the cell wall, also cause the death of the bacteria. So with mechanism, these 2 points were important, like penicillin binding protein or your autolysis. Then some gram negative bacteria. They start secreting, they synthesize and secrete beta lactamase enzyme. This is our beta lactam ring. This will destroy our beta lactam molecule. So along with the beta lactam, we started giving clavulanic acid. This clavulanic acid inhibit this enzyme and our drug will work, kill the bacteria. So this is the amoxiclav means clavulanic acid inhibit the enzyme and still our drug is working. So they have asked one competitive exam that amoxicillin and your Ca they are combined in which ratio? That is your 4:1. Similarly, in sulfonamide we have studied that sulfonamide is to TMP. As for S, that is 5:1. But here amoxicillin is 4 and your clavulanic acid is 1. So this ratio is also important. Similarly, we have Ticard saline combination, sulbactam, tazobactam. These beta lactamase inhibitors are also known as suicide inhibitors because there is the suicide of the uh, clavulanic acid. It combined with the beta lactamase initially reversibly, then it form a permanent covalent bond that may lead to the suicide. So similar to penicillins, PCM, the second member is cephalosporin. Cephalosporin. This is also obtained from the fungus. Initially, from the cephalosporin fungus, there were three types P and C. P for positive, kill the positive, and for kill the negative, and this is for common for both. So we want to utilize this because it is able to kill positive, negative both. So all the cephalosporins they are derived from type C. So that is important. Type C. There are five generations of cephalosporin in the module. One trick is given that is first generation, how to remember second, third, fourth, and fifth. In case of first generation, A for A, first means A. You will find most of the drug have A in their common name. For 3, me, 1, 10. Ceftriaxone, C4, Taxim, like this. They have this uh, tricky word in them. Fourth generation, they have PI inside them. And fifth generation have one that is ROLE, role. The remaining all other are your second generation. So this is how we can remember the five generation. First generation for A, in the name they will find cefaclor, cephaloridin A. Then for third generation, three common word are me, 1, 10. For fourth, pi, and fifth, role, biprol and septarol. So ROLE. There is one more term which is related with cephalosporin, that is cefamycin. This is known as 7-methoxycephalosporin. Means at the this is the cephalosporin. At the position number 7, we add this group. That is your 7-methoxy group. So these cefamycin they are obtained from bacteria, but cephalosporin obtained from fungus. This is the one difference. Source is bacteria, source is fungus, and these are 7-methoxy derivatives. This was asked in one MCQ that cefamycin are 7-methoxy, 5-methoxy, or 4-methoxy. Answer is 7-methoxy. And the mechanism of cephalosporin is same as penicillin. Bind with the penicillin binding proteins. Then the next member of PCCM is carbapenem. Carbapenem, two members are more important. One is your imipenem, and the second member is your meropenem. The important point about this, in the kidney, in the kidney there is one enzyme. This enzyme destroy our drug. It has the ability to destroy our drug. So what we give, cilastatin. This molecule is added with the drug, and this molecule inhibits the enzyme so that our drug can easily work. But in case of meropenem, no need to add cilastatin. This is the important difference. Second more important difference is, in case of imipenem, the side effect is seizures. But in case of meropenem, either absent or less or low incidence of seizures. These are two important points with imipenem and your meropenem. Cilastatin not required. Seizure is more common. Seizure is less common. So carbapenem. Mechanism is same, like binding with the penicillin binding protein. The last beta-lactam is your member of your PCM is your M. M means monobactam. Mono means one. There is only one ring. And there is only one example. That is Aztreonam. So this is Aztreonam monobactam. And this monobactam, if we look at the M, make it like 3. It will bind with your penicillin binding protein 3. That is the more important for monobactam, bind with the PBP3. Then we have some protein synthesis inhibitors, like starting with the bacteria. Bacteria have cell wall. So the cell wall active drug are beta lactam. These are beta lactam. Then we done with DNA drug, that is your fluoroquinolone. They inhibit the replication. Then metabolic pathways inhibiting drug, that are your sulfa drug. So three category of drug: cell wall, with the DNA, with the pathways. And the next category of drug comes to be which act as the level of ribosomes. So the main role of the ribosome is protein synthesis. Suppose this is your messenger RNA, and these are the ribosomal subunit. These are the ribosomal subunit, which is made up of A site, P site, and exit site. The tRNA come with amino acid and sit at the incoming site. That is always first time come with P site. So there is one group of drug tetracycline. Tetracycline inhibit this incoming tRNA or charged tRNA to take the amino acid at the initiation site. So it inhibit initiation, that is at 30S subunit. Then second, we have aminoglycoside. Aminoglycoside also act at 30S. They lead to misreading, misreading of our genetic code, misreading of genetic code. If there is misreading, that may lead to formation of the misprotein, that is sidal protein, and this sidal protein will kill the bacteria. So aminoglycoside are bactericidal drug. They make a protein which is sidal in nature to kill the bacteria. Second, we have chloramphenicol. Chloramphenicol. So chloramphenicol act at site of action is 50S. Similarly, we have macrolides. They also act as 50S. So chloramphenicol does not allow two amino acid to combine with each other. It means there is one enzyme, peptidyl transferase. It blocks that enzyme that these amino acids are not joined with each other. So premature termination of the polypeptide chain. So first member is your minoglycoside. Minoglycoside carry positive charge on their surface. So if they are carry positive charge means they are polar in nature. And the more important thing for they distribute only to extracellular fluid. They never enter into the inside the cell, intracellular fluid. So the mechanism of action for all these, first is the, suppose this is your bacteria, having outside is the cell wall. The first is entry into the bacteria, first step. If it enter and that entry is oxygen dependent. If we remove the oxygen, make this bacteria anaerobic, then it will become resistant to aminoglycoside. So anaerobic bacteria are resistant to aminoglycoside. So oxygen is important, and this oxygen is generated by your ATS system, electron transport system. So this is important. Second, if the aminoglycoside enter inside, it will reach at the site of ribosomes. And then ribosomes 30S subunit is the site or the target of your aminoglycoside. So there is one mnemonic, bind at 30, bind at 30. 30 subunit, A for aminoglycoside, T for tetracycline. So first there is entry into the cell, that is oxygen dependent, and second is the bind with the ribosome. And this binding may cause misreading of genetic code, and suppose this is the shape of the protein which was normally formed, now this will formed like this. So there is misreading and it will form a false protein that most of the time is cidal in nature, kill the bacteria. So bactericidal. So aminoglycoside are bactericidal. So the examples are narrow spectrum, broad spectrum. You can remember that. So the important things for aminoglycoside, that is polar nature. Second, concentration dependent killing, post antibiotic effect. So if we draw this curve, plasma concentration, then this will be the seed concentration, and it this is MIC. It goes below the MIC, that is your PAE, post antibiotic effect. So these are two important points. Concentration dependent killing. If you increase the dose, it will kill more. And after the dose or concentration goes below the MIC, still killing for few hours. That is because of post antibiotic effect. Then minoglycoside toxicity. One is more important is nephrotoxic. In case of nephrons, there are PCT cells, PCT, proximal tubular cells. See, aminoglycoside, this is aminoglycoside carry positive charges. And this membrane of the PCT cell contain phospholipid, negative charge. Positive negative attract and they come inside. Inside they enter into lysosome, and lysosome burst and the death of the PCT cell. Cell death. This may lead to your damage to the kidney. Or this negative phospholipid, the more commonly involved is phosphatidyl inositol. This is involved. So this is nephrotoxic. The most toxic for the kidney, that is most nephrotoxic aminoglycoside N4N. Most nephrotoxic is your neomycin. Neomycin. Then second is neuromuscular blockade, NM blockade. At the site of neuromuscular junction, nerve and muscle junction, if we look, this is the neuron and this nerve ending. The mechanism is calcium enter the vesicle filled with acetylcholine, exocytosis, and this is the muscles having receptor. It will act on the receptor. So aminoglycoside, they also carry positive charges. So it repel the calcium and do not allow this calcium. So no exocytosis, no acetylcholine, no muscle contraction. So this is neuromuscular blockade, nerve and muscle blockade. That is because of positive charges repel, no calcium entry, no exocytosis, no muscle contraction, neuromuscular blockade. Third toxicity is in case of ear ototoxicity. If we look at the structure of the ear, there are some fluid, endolymph and perilymph. Perilymph. Aminoglycoside enter into these fluid. Aminoglycoside enter and it will accumulate and damage the hair cells. So there will be ototoxicity. And the excretion from these fluid entry is rapid but exit is slow. Because of this slow exit, they keep on destroying hair cells. then there will be ototoxicity. So three important toxicity with aminoglycoside: nephro, neuromuscular, and ototoxicity. Then one more with the neomycin. Suppose this is your neomycin. As aminoglycoside are polar molecule having positive charges. So this is the neomycin enter into the GIT. So we use the neomycin powder for the local gut sterilization before surgery to reduce the contamination load. To reduce the contamination load before surgery, we give neomycin powder that will not absorb less than 3% absorption, nearly negligible, so it will remain here and destroy all the pathogenic bacteria because it is bactericidal. So we use this as a gut sterilization before surgery to reduce the contamination of bacteria. This is important regarding the neomycin. There is one MCQ regarded with amikacin. So aminoglycosides, they secrete some of the enzymes, but this is the only aminoglycoside which is resistant with these enzymes, not destroyed by. Out of all aminoglycoside, it is the amikacin. These are your transferases enzymes, and this drug amikacin is not susceptible. It is resistant to this. So if you find gentamicin resistance in some bacteria, then we go for amikacin because there is no resistance related with these enzymes. Then few important point about your tetracyclines. Tetracyclines. There are 2 points. One is related with the teeth and one is related with the bones. So tetracycline, they combine with the calcium, chelate the calcium, and they lead to damage of these structures. When these structures are forming structures, when they are there is deposition, the tetracycline impair with this. And one important with the tetracycline is Fanconi syndrome. Fanconi syndrome. Fanconi syndrome means if tetracycline is used after expiry date, that may lead to some toxic metabolite, and these metabolite may cause the side effect. That may be your Fanconi syndrome. Then with tetracycline, there are two lipid soluble. One is doxycycline, minocycline. These are drug of choice for your Ehrlichia species. Ehrlichia rickettsial species, doxy is the drug of choice. And because they are lipid soluble, excreted out in bile, doxy and minocycline. And one more MCQ, that is related with the drug demiclocycline. In case of nephron, if you look at the collecting duct, the last portion, at this portion ADH work and it puts some aquaporins and absorb the H2O. It absorbs the H2O. So this demiclocycline, it inhibits the action of the ADH. Either it blocks the receptors and stop the function of ADH. So we used this drug in case of a syndrome SIADH, syndrome of inappropriate excessive secretion of ADH. If more ADH come, we give demeclocycline. It will inhibit its receptors and excess will not work. So this related with your demeclocycline. Then chloramphenicol group. With chloramphenicol, if this is the structure of chloramphenicol, para group contain NO2, nitro. This is responsible for your bone marrow suppression. That may be of two types. One is dose dependent. One is dose independent. Dose dependent means if you increase the dose, bone marrow will suppress. If you decrease the dose, it will come back. So this is known as reversible. This is known as reversible, but independent of the dose. I for I, that is irreversible. This dose dependent or reversible present in all animals, but this one is present only in case of human being, not in animal. So chloramphenicol we can use in case of animal because this is reversible bone marrow suppression. But in case of human being, this is irreversible. That is known as aplastic anemia because of bone marrow suppression. So this nitro group is responsible for this. If we remove this nitro group, then there will be no bone marrow suppression. And we put some molecule here, it will become thiamphenicol, thiamphenicol or fluorphenicol if we add fluorine atom. So these thiamphenicol and other molecules, they are safe as per your bone marrow suppression is concerned because the molecule was NO2 group. Dose dependent means reversible, increase the dose, toxicity increase, decrease, come to normal. That in all animals. Independent eye for eye, irreversible, occur in case of human being. With this chloramphenicol, one more MCQ is gray baby syndrome. The baby skin color becomes gray. So this is gray baby. The enzyme, the liver contain enzyme which metabolize your chloramphenicol. Chloramphenicol. That is by the pathway glucuronidation. So in case of human infant neonate, this system is not developed well, it is weak. That may lead to accumulation of this chloramphenicol molecule that may cause gray baby syndrome. Similarly, in case of cat, glucuronidation is absent or it is negligible. So cats accumulate chloramphenicol because of absence of glucuronidation. Because the main mechanism which metabolize your molecule chloramphenicol is glucuronidation. In case of human being, gray baby. In case of cat, toxicity. Then macrolides. Macrolides are also working on your 50 S. Same mechanism, but the important member here is erythromycin. Erythromycin. Erythromycin having its spectrum only for gram-positive bacteria, which is nothing but similar to your penicillin G. So we call erythromycin as penicillin substitute. Means if a patient is hypersensitive to penicillin, we can use their erythromycin. Spectrum of both is narrow, gram positive. So these are penicillin substitute. Second one related with erythromycin is prokinetic. It is prokinetic effect. Because in GIT there are some receptor known as motilin receptor. So it stimulates the motilin receptor that may increase the contraction peristalsis of GIT. So prokinetic. So two MCQ with erythromycin penicillin substitute as well as prokinetic effect. Then there is one more drug called tylosin. This is drug of choice for mycoplasma. Mycoplasma that causes your CRD in poultry. Chronic respiratory diseases. This is the drug of choice. Then one more molecule in macrolide is azithromycin. The specific feature for azithromycin, it accumulates inside the cell more. So it is able to kill all the bacteria which are present inside the cell. That is your Mycobacterium tuberculosis, like your Brucella or other intracellular chlamydia, mycoplasma. If these are the intracellular, they are killed by your azithromycin because it more accumulate inside the cell. So this was about your group, like for DNA, fluoroquinolone, for cell wall, your beta lactam, that is PCM, and for ribosomes we have aminoglycoside, tetracycline both at 30S, all other like your macrolide, chloramphenicol, they are acting at 50S. In all the cases, the first step will be entry into the bacteria, and second will be with the action with the ribosome. In some cases, this entry is oxygen dependent. That is your aminoglycoside. So these are some of the classes where we discuss acting on cell wall, some on DNA, ribosome, and metabolic pathway A, B, C, D. That is your sulfonamides. So in chemotherapy, most of the questions they have asked from your mechanism of action, then classification, sometimes resistance, and some specific drug like erythromycin prokinetic action, antibiotic having prokinetic action. Then their side effect. This is the more important part related with the side effect. because there are many MCQs like gray baby syndrome, Fanconi syndrome, tetracycline. Then hypersensitivity reactions, your penicillins. KCS, dry eye, your sulfonamide, S for S, sulfonamide. Then crystal urea, both sulfa drug as well as your fluoroquinolone. So the side effect, and then this vitamin K deficiency, sulfonamide. So first is mechanism of action, second classification, and third more important is side effect. Then other like resistance history. First is mechanism, second classification, third your side effect. This is the order to read your chemotherapy portion. Uh, so antifungal, then antiviral, your anti-cancer, and anti-helminthic. These four and parasiticide like anticoccidia. These four topics will cover in your evening lecture. If you have any doubt regarding this beta-lactam and protein synthesis inhibitor or your synthetic ones like sulfonamide and fluoroquinolones or in case of general chemotherapy with definitions, you can ask any question. Hello?
Sir, which antibiotic has prophylactic actions?
That your erythromycin, your erythromycin. Because if you look at the GIT of mostly cat, in cat there is one receptor that increase the motility. So from the motility, the name is given motilin receptor. It increase the motility. That is your prokinetic action, erythromycin. And second, their spectrum is very narrow, only limited to gram-positive. We call them penicillin substitute. Because if one patient is having hypersensitivity to your penicillin, so we can go for erythromycin because they do not cause hypersensitivity reaction. So the motilin and receptor would increase the motility, we call them prokinetics. This is present in your cat mainly. Other may have, but more important with cats.
Tetracycline's action on bone and teeth.
Okay. Uh, in case of tetracycline, Normally, bone deposition, these pair they get deposit with the when the formation of bone. Once the formation stop, your tetracycline will not cause any harmful effect. So we call these are under the 18 month, means young age when the developing teeth, developing bones, then your tetracycline they chelate the calcium and in case of teeth they may cause mottling of teeth. And here the bone portion where they are depositing. So the tetracycline they chelate the calcium because they have more affinity and that may lead to bone weakening, bone porosity, or that may lead to fractures of bone also. Then, but in case of your fluoroquinolones, the effect on cartilage is more important. Suppose these are the articular cartilage, and for their growth or deposition, they require magnesium. And your fluoroquinolones, as like tetracycline, they chelate the cation magnesium. And because of deficiency of magnesium, there will be damage to these articular cartilage. So they cause the damage to articular fluoroquinolone because they chelate the magnesium, which is important for the growth of the cartilages. Mm, then structure activity is completed, progressive, different. So one more MCQ that with your sulfonamide, mostly sulfonamide have alkaline pH and high alkaline pH always cause the pain on injection. But there is one sodium sulfacetamide. This is the exception which is having neutral pH. So the pH is neutral, so we can put this drug into the ice. So eye drops are available of this molecule in the market, sodium sulfacetamide. So because of neutral pH, it does not cause any harm to the eye. We can use it for the eye. Similarly, in fluoroquinolones for the eye, we use moxifloxacin. That is very important, which is high fourth generation fluoroquinolone. So in case of cephalosporins, we have 5 generations, and as I told you, the trick to remember these 5 generations. If one for A, that is all the cephaloridin cephalo contain A. 3 means this 3 is me, ceftriaxone me and 10C for them. Then this will contain only one word PI pi and fifth contain rol in their name. Other are second generation. So there are total 5 generations. Cephalosporin. Then adverse reaction. One term. I mean, one term is super infection. Super infection. Super infection means suppose in case of GIT, this is the part where there is infection is present. Infection is present. If we administered one broad spectrum like your tetracycline antibiotic, OTC, or any other, this will come and along there are some happy bacteria. These are your normal healthy bacteria which fight with the pathogenic one. So this static drug we give we give for the treatment of infections. So along with the pathogenic, it also start killing your healthy bacteria. These healthy bacteria are killed. If you kill the healthy bacteria, then these pathogenic will multiply more. And instead of treating that infection, we have created one more infection that is called super infection. And this super infection is because of the what we call indiscriminate use of your broad spectrum. Because their spectrum is broad, so they can kill normal flora as well as pathogenic. If normal is killed, pathogenic will flourish, multiply their number. Again, one more infection start developing. So this is super infection. Same with your broad spectrum antibiotic like tetracycline. So only 4 or 4 to 5 classes are remaining in like antiviral cancer and that will cover in evening class. Hello, any doubt?